the force, direction, values. Alright, what are the three bands of the UCL? Anterior, posterior, transverse. Transverse is a little unique. Why?
Keeps your low head for sliding.
Okay, so its attachment points are on what bones?
Trochlear notch. And
It kind of covers the trochlear notch. So trochlear notch sits here, transverse goes across it, coronoid into the olecranon to cover that trochlear so that the trochlea can't slip sideways and get out. What are the other ligaments of the elbow? The RCL, radiocollateral. What's it resist against? Varus force. What else do we have? The LUCL. And what's it do? What's it do?
rotary instability.
It's preventing rotary instability. What bones is the LUCL attached to? What bones is the lateral ulnar collateral ligament attached to? Ulna, it's its name. Nope. There you go. So what's it doing? Lateral side, we have a strip of that. So if you go back and remember, once it pops up, we look at the lateral elbow. The banding for the RCL is kind of a pyramid shape, and the peak of it, the apex, is on the humerus. So it's coming from a singular point, and it fans out in somewhat of a deltoid shape, a delta shape. All right? So the RCL, whereas this labels all of it the RCL, the radiocollateral ligament is the fibers that attach the humerus to the radius, stabilizing that point of that joint. Varus force against pushing the radius off the side. The posterior fibers make up the lateral ulnar collateral. So it's stabilizing the humerus into the ulna on the lateral side. So it's a reinforcement. And many pictures are going to show it this way, where they want to identify that RCL as a singular piece. They'll show it connect to the ulna, but they don't want to relabel it, just to make your life a little bit more frustrating. But the posterior fibers of the RCL are actually the lateral ulnar collateral ligament, stabilizing the lateral side of the humeral ulnar joint. Okay. What's the last one that we haven't discussed? What's the last ligament that we need to focus on in the elbow? The annular. So ring, annular ligament. So it is pretty much a sling that holds the radial head in place. All right, then from there, let's start talking about, well, what are the muscles of elbow flexion? Biceps brachii, brachioradialis, brachialis. What's the principal muscle for extension? Triceps brachii. What does the anconeus do?
Stabilizes the ulna.
Anconeus. So it's going from lateral epicondyle posterior to the radius. Oh, sorry, to the ulna, my bad. It holds the ulna in place. It stabilizes that ulna as we go through extension. Good? So it's going into that proximal shaft distal to the olecranon to help stabilize it in place as your triceps pull you into extension. So not inherently an elbow extender itself, but it does help stabilize that ulna in the process. Alright, so from that point, we have an absolute ton of muscles to cover. So brachioradialis we've chatted about, it's the most superficial, so we can hide them out of the way. We can get brachialis out of the way. We get biceps out of the way. There's a half a biceps. Alright. So we've done this once, so we can cover it a little more quickly. We're going to focus on let's go on this. What is the function of that? Bicipital aponeurosis, what is its role?
To hold all of the muscles right there.
Nope. What does it do? It's got a name like a muscle, sort of. So it's an attachment of the biceps. So the biceps brachii inserts into what primary or principal landmark? What's the insertion point of the biceps brachii? Radial tuberosity. It has fibers that actually flow off of it, though, that go into this bicipital aponeurosis. It's wrapping into the fascia. So your biceps isn't just yanking up on the bone, but it's actually integrated with most of the muscle in the area by being directly attached to the fascia through this aponeurosis. So it's a tissue that means that when the bicep pulls, it's grabbing most of that soft tissue to go with it. So it's an increased leverage point by helping it grab into a lot of soft as well as the hard of the bone. And now it's gone. Alright, so hand trick. Arm on the table, heel of the hand, crook of the elbow, antecubital space, and you got fingers. Good? And just like British tea, we leave our pinky hanging off the side, kind of floppy and useless. Because you just can't drink tea any other way. Alright, so let's talk about the other fingers. What is the thumb? Pronator teres, direction of the fibers. Pronator teres. Good? And it's gone. Next one, index finger. Flexor carpi radialis. Index finger on the radial bone, flexor carpi radialis, inserting into the base of the second and third metacarpals. So just past your carpal bones, it goes in the base of the second and third, index and middle finger. All right, flexor carpi ulnaris, ring finger. Goes along the ulnar bone into the base of the fourth and fifth to help flex along the ulnar side as well. So those two together create an even balanced wrist flexion. So that leaves our middle finger, which is three muscles. Palmaris longus. It inserts into the palmar aponeurosis, and the flexor retinaculum. So it's going into the soft tissue of the hand to pull it forward. Again, not a bony landmark. It's relatively undeveloped, not a very big, strong, powerful muscle. Then we have flexor digitorum superficialis, so the more superficial of the finger flexors. There's palmaris longus, out and out the way.
SCS and FTP in middle.
Flexor carpi ulnaris. Have that one out of the way. And that leaves us flexor digitorum superficialis. So coming off a significant portion of the radial shaft, it's coming off of the same common flexor origin that all of the others are coming off of. Where does it insert?
Middle phalanx.
Middle what?
Phalanx.
Middle phalanx. So it crosses the PIP, the proximal interphalangeal joint, inserts into the middle phalanx. So it flexes at the middle phalanx. It will also assist flexion at the carpal metacarpal. It will also assist flexion at the wrist. This muscle attaching here is much more powerful than its buddy that's deeper, the FDP. So you get strength in your grip from your FDS. A piece to note is on this distal insertion. We'll cover this a little bit later as well. But notice that the distal insertion splits. So we have tendons that go wide with another tendon punching through the middle, which is really pretty unique. Usually a deeper muscle will start later and end sooner, where the more superficial will go up over like a bridge. In this instance, we have FDS that splits so that the tendon of FDP, flexor digitorum profundus, can slide on through to come out to the distal phalanx across that distal interphalangeal joint. It makes for some unique scenarios with injury, among other things. So FDP is the last of these, the deepest layer, flexor digitorum profundus. FDP goes to the distal phalanx. So let the letters help you out. Flexor digitorum profundus, FDP, goes to the distal phalanx across the DIP, the distal interphalangeal joint. So keep putting those DPs together and you'll understand where it's going. Now this is fine motor control because it's the tip of your finger. Now we've had a conversation about retinacula before, right? What do they do? What are they for?
Hold tendons down.
Kind of hold tendons down, right? So we're having a flexor retinaculum that's going to go over the wrist. So if I do this, I don't bowstring across that space. Well, in many ways, this FDP tendon has several tethers all the way through. Little tunnels that kind of hold it so it doesn't bowstring anywhere. So as you get into hand and finger injuries in the next couple of days in ortho, as somebody, if I come up and I grab an arm, and as she's pulling away, my fingers start to slip off. It puts a tremendous load into fourth and fifth, predominantly fifth as I'm falling away from you. So what we end up with is an eccentric load that's increasing in significant levels as we ping, ping, ping each of our fingers off. And it ultimately avulses, it rips FDP off of the distal phalanx on fourth or fifth, more often fifth. So it's going to give me a situation where I've avulsed that distal tendon. Now the force of that contraction of that muscle, as well as the sudden release, means that tendon is usually going to retract down my hand, down into my hand. Depending upon how far back it goes, it changes how much difficulty the hand surgeon is going to have. Regardless, that injury, avulsing FDP, will inherently require you to have surgery to go in, fish it out, reattach it with a staple, and leave it there for a period of time. Yay, fun. So FDP, that it's called a jersey finger, and it happens because as you're grabbing on somebody's jersey and they slip off, it avulses. That sudden load pops it off. All right, so we're gonna. Oh yeah, go ahead.
I have a question about like flexion and extension. So,
Sure.
Like some people can go back farther than other people.
Yeah.
Like, why does that change? Doesn't like. Why?
So some of it's muscle flexion, muscle ability and tension. I mean, some people can crank it back. So you're going to have a restriction, like anywhere, with two main structures. Either the ligaments that band it, or with the tendons that control it as well. Most people, when they do this, they're going to feel a stretch within the muscles. And you'll feel that pull up and through here. Now,
Because like in synchro, we'll do like moves like this, and we're like match your wrist. Well, some people can like go really far, and some people can't.
some of it's joint mechanics, some of it's tensioning within the muscles. To where you, if this is tight, then you're going to have issues. So, crazy, unique story about me. I played alto sax growing up, so you're always in here. So, starting in the 5th grade, I was playing alto sax. And I was at dinner one time, and there was a picture of Michael Jordan. And it was one of like those life size, but it was a panoramic picture of him holding a ball like this. And it showed the size of his hand, so we got in a conversation about hand size at the dinner table. And so we put our hands down on the table, just like, hey, look at the size of the hands, trying to look up, compare it to Michael Jordan's. Clearly mine is much, much smaller. But when we did that, my fingers went like this. So they bow a little bit. And it was all tension. Because I always sat here, I never did anything that stretched out to extend. So I had a limitation. So when I went to match hands, when I went to the tension within the tendons would have kept me flexed. So where's a lot of that coming from? A bit of it, I mean, is going to be flexibility of the flexor tendons, to where you can stretch some of that out. Now, to some extent, you're also going to have it as the ligaments that band through here, and certainly the geometry of the bones that make up the wrist joint. But it's as an ellipsoidal joint, that's pretty free range. You can crank it. It's a soft end feel. The end feel on that is definitely a restriction from the tension of those tendons. You're not hitting firm, so you can work on it some. Clearly, you need to spend some time with that. So, yeah. So forever, like I'll do this, and you like popping your knuckles, and no, it's like still implanted in my head to stretch out my. All right. You know how they figured I needed glasses? I got a needs improvement on my scissor cutting in kindergarten. I still remember when I walked out of the optometrist with my glasses on the first time, and like the car tire looked huge. Whoa! It's huge! And I've been in it ever since. So. Anyways, all right. So FDS goes away. That leaves us with FTP. Next, our tutorial for. Now, I've seen some unique injuries with FTP before. So I have baseball players that come in and they go, okay, so when I'm working out, and I'm doing bar curls, like bicep curls with a bar, straight bar, I'm fine. But when I go to set the bar down, as I relax the weight, I get a stabbing pain in through the side of my arm. Like just an immediate shock, like right in through here. So what we figured out is that, so that's FTP to the 4th and 5th digit that's going to come in right on that side. And so because of a weakness in grip strength, the biceps is fine, and holding it when the rest of the muscle is engaged is fine. But as they were releasing, going eccentric, and you tend to unload index fingers first, that was putting enough load in there on a weakened muscle that it was grossly inflamed. So you touch just up underneath on that ulnar shaft, and then they get this pretty, yep, that's it. That's pretty stabbing pain right up in there. So again, recognizing where you have origins and insertions is going to help you kind of figure some things out. All right, so last two muscles that leaves us with. So this is the one that has a unique origin because it's not coming off the common flexor origin. That's flexor pollicis longus. And then the last one, and that goes to the distal phalanx. The last one is pronator quadratus, which is assisting in that pronation. Your wristwatch muscle. So it's right on the anterior side, anatomical position of where your wristwatch would go. So, that leaves us a slew of muscles to go in the back. We haven't done those yet, so this is all fresh and new. So we're going to do this in 3 different pieces. The first piece is going to be the corollaries to the palm trick we did on the other side. Okay, so we'll start here. This will give us 5 of the muscles. The next one is going to be hook 'em horns. And the last piece is anatomical snuff box for a total of 10 muscles, 5, 2, and 3. Okay? So, let's start here. Heel of the hand in the crook of the elbow, antecubital space. What muscle is the thumb? Pronator teres. So, I'm not asking you to turn your hand over. I just want you to know the corollary, like deep underneath that finger as we go through. So, pronator teres is the thumb. The opposite motion of that is going to be the supinator. It's very finis and firm. Because we have to make more innators. Right? So this is the supinator. This makes soup, apparently. Because whatever his innator does is what it, you get. Phineas and Ferb is one of the greatest cartoons ever made. Period. If you haven't watched it, then your life is incomplete. The only way I know what an aglet is. Do you know what an aglet is?
Yeah, it's the thing that covers the edge.
You know that because of Phineas and Ferb.
No.
Yes, you do. Don't lie to me. All right. So, supinator, first one. It's not the most superficial. We're not going in order of superficial to deep. Just the easiest way is to kind of remember. Pronator teres, that pronates it. Supinator, that supinates it. Simple enough? Excellent. Index finger. What's its corollary? Well, what's the hand trick? Flexor, carpi, radialis. So, on the other side, we have extensor, carpi, radialis, but there's a longus and a brevis. So there's 2. Longus goes to second metacarpal, base of second. Brevis goes to base of third. Simple enough. Same origin for all of these. Extensor, common extensor origin, which is going to be your lateral epicondyle. Okay? All right, so supinator, extensor, carpi, radialis, longus, and brevis. What's your ring finger? Flexor, carpi, ulnaris. So its corollary, extensor, carpi, ulnaris. Good? So I said there's 5 muscles: supinator, extensor, carpi, radialis, longus, and brevis. Extensor, carpi, ulnaris. What's your middle finger? It's a series of 3 muscles, right? On the anterior surface. Palmaris longus. FDS, FDP. Extensor digitorum. Done. 5 muscles. Just know this trick first, and then you can hold on to the corollaries. Extensor digitorum, just 1. Now, we'll pause on extensor digitorum real quick, because it's kind of cool. This is it right here. Nope, that's it right there. There we go. Alright, so in this, what this doesn't show well or at all is that over the top of the back of the finger, we have something called the extensor hood. So it's almost like a blanket that gets kind of wrapped on. Ligamentous attachment points. So this extensor is actually attached at each of these segments. It's not just at the distal phalanx. It's attached in each of the others. And then there's tendons. If you remember lumbricals, lumbricals come from underneath and grab into that extensor hood to create their attachment point. So extensor digitorum is really kind of cool because it's going over the back of a finger with a whole lot of attachment spots. So what does that mean? Well, if I throw a basketball at your face, and you reach out to catch it, and you miss, and it just tips your finger, well, you're tense, and then you take a sudden load, you can avulse extensor digitorum. It's called mallet finger. Your finger is, well, you've popped it, so it kind of, you can't flex it. You can't, sorry, you popped it off the back, which means it sits forward. Right? And then you ask them to move it, and they're like, I can't. I can't move my finger. And then you hold it up for them, and you say, okay, now hold it there. Don't let it fall. They go, okay, got it. And he goes, whoop. My finger. Okay, so because we have this extensor hood, it doesn't retract like FDP. It's still there. Because it's already still attached here, it doesn't have anywhere to go. Which means it'll heal itself, as long as you know how to take care of it. You go and put it in a splint in some subtle hyperextension, and you leave it there for 8 weeks, and it will reattach and heal itself just fine. So, FDP has a single point of attachment, and it retracts downward, potentially into the hand, which is all problematic. That takes surgical repair. Jersey finger takes surgical repair. Extensor digitorum, proper splinting, problem solved. You miss the proper splinting, or the young darling doesn't want to keep a splint on, and they will have limitations in their hand use for the rest of their life. No problem. Seen that. High school senior refused to keep his splint on. Alright, so, let's see, what can we get rid of? Extensor digitorum, we can make go away. These two thin bands underneath brachyradialis. Oh, terminology that I don't know how useful or important or helpful this is at all, but you may see it at some point in your life. Again, brachyradialis sits across the top. It's the most proximal attachment of all of this common extensor muscles. So right underneath it, as you can kind of see here, is brachyradialis has been pulled off, and so your extensor carpi radialis longus, and brevis is directly underneath it. That makes up kind of this lump of muscles right here. So you can kind of grab it and shift it around. Yeah. So it's referred to sometimes as the mobile wad of 3. I only say that for the sake of, I think I learned it in my undergrad. I think I've seen it on an exam once in my life. And I've heard other people say that they have seen it referenced places. So, mobile wad of 3. It's just a random brachyradialis and extensor carpi radialis longus and brevis. It's that 3 set sitting right up in here that you can grab and mobilize, I guess. There you go. Alright, that one's gone. That one's gone. So now with those 3, with that mobile wad of 3 gone, you can finally see supinator. So it's deep to all of those guys, but it's in there. But we've talked about it, so we can go into it. So extensor carpi ulnaris, we chatted about him. Now he's gone. So that's our 5, right? From the hand trick, we know all the ones in the front, and then from the hand trick, we can figure out supinator, extensor carpi radialis longus and brevis, extensor carpi ulnaris, extensor digitorum. Good. 5 muscles, that means we have 5 to go. The second one is Hookham horns. So what am I doing in Hookham horns? I'm extending what fingers?
Your
Index and my pinky, right? So extensor indicus and extensor digiti minimi. That's it. That's the next 2. So extensor digiti minimi has that common extensor origin. Extensor indicus is not. Distal shaft of the ulna. All right. Gone. And gone. So that leaves 3 muscles. Anatomical snuff box. Take your hand and extend it out. At the base of your thumb, you see this lovely little divot called your snuff box. My understanding is that women in fancy dresses would keep their snuff in that little spot. Keep the little pick-me-up for the party. Regardless, if you poke in that hole, you are poking onto the edge of the external edge of your scaphoid. The scaphoid sits right in through here, and you're poking sideways into it. If you then relax your hand, take 2 fingers, find your snuff box, put your 2 fingers on that gap, relax your hand and rest, you should feel a pulse. So radial artery comes right through here, and then crosses up and over, goes over the scaphoid through that snuff box, and then goes in the webbing of your hand. You can actually, if you take 2 fingers onto the webbing of your hand, typically find that radial pulse in here as well, in the webbing between your thumb and your, but it gets smaller there. But it's findable, sometimes. Apparently I'm dead, I don't have one. There it is, I live again. Resurrection after 30 seconds. Cool. Alright, so anatomical snuff box. So you've got your scaphoid in there, you can find the radial artery, and then the borders of it. If you go more posterior, towards, again, so once we hit the hand, we go back to like the foot, to where we have the middle finger becomes the midline of the hand. So medial versus lateral, we can try to reference an anatomical position, but at the hand, everything kind of becomes midline, becomes middle, third ray. So more towards the midline, towards the medial aspect, towards that third ray, you have one tendon, and then lateral, away from that midline, you've got a pair of tendons. So this is extensor pollicis longus, and then the snuff box, and then extensor pollicis brevis is on the lateral side, along with abductor pollicis longus. Okay? So my extensors get split with the gap in the middle, and then my brevis is paired up with abductor pollicis longus. So there's longus, extensor pollicis longus. There's my snuff box. There's brevis. And there's abductor pollicis longus. So each of those goes to a different insertion point as well. Extensor pollicis brevis goes to distal. Longus goes to distal. Brevis goes to proximal. And then abductor pollicis goes to the base of the first metacarpal. That gets us into the hand. Now you see all this fun heavy purple stuff in here? Yeah, ain't for purple stuff. What is it? Sheath. So what kind of sheathing? You'll see some of it, big mass of it in through here. We have one sitting right there. We have one that comes all the way down to there. What is it? What is that sheathing for? What kind of sheathing is it? What does it do? I don't know. Don't ask me. Friction. So whenever I have a tendon that's going to go pass through a very mobile joint, very real possibility that that tendon, as it moves, is going to rub on stuff. So the sheathing is synovial sheathing, and it's geared to where that tendon has a tunnel to pass through. Excellent. No friction, no pain, no degradation, no problems, unless there is. So the problem with that is knowing that it's there, because the damage you can cause, once you get into modalities, you'll get to start hanging out with this information, but the injury response, I damage a cell, I trigger this inflammatory response, it's just chemicals showing up in his face. As those chemicals show up in his face, it triggers more chemicals to show up. It triggers your body to clean up the damage so we can put down new. And a lot of those, well, it tells us that it hurts. It's our body's way of saying, hey dummy, you broke it, stop using it until we can heal it. Simple enough. Now the problem though is that these areas don't get a lot of circulation. So we can damage a tendon and then your body can fix it and it's all yay hunky-dory fine, except those chemicals still get kind of caught up in that space. And when they're in there, you're going to have a constant sensation that it hurts to use it. So this area, especially for those tendons that make up your snuff box, up in here, the sheathing in those spaces can cause some pretty significant pain and dysfunction. You'll get to a disease state called Dequervains. Dequervains, D-E-Q-U-E-R, it's French. And it's inflammation in those the thumb extensor tendons within the synovial sheathing. So it's called tenosynovitis. It's tendon synovial sheathing itis inflammation. And it's a booger to get rid of. Just because, again, most of those places you don't have a lot of blood flow through them, and so it's hard to coax those chemicals out without triggering them to bring more buddies along. But the cool part, you guys ever heard the term crepitus? Yeah? You ever felt crepitus? Try it sometime. So it feels like what a squeaky hinge sounds like. So you'll feel that kind of stick and slip as your fingers are on that tendon sheath. I think the first place you may find it is within your careers, maybe the Achilles tendinopathy. So on the Achilles tendon, and especially if it's swollen, very gently touch it because it will be very tender. But put your fingers on that swollen spot and have them plantar and dorsiflex, and you can feel it, that tendon slipping in around all the extra fluid and the chemicals in there. Yeah, it's very weird, cool, painful, all at the same time. But Dequervains is one of those issues. So if you take your thumb and you grab it and you go into ulnar deviation, that puts a stretch on it. It's called Finkelstein's test, but it lights that person up. Doesn't feel good for most people. There's a modified version to where you can actually do it, like hold pressure here and then come inward on it. So instead of going down, which puts a lot of stretch, you're just coming across, and that works. My hand specialist taught me that one, saying it works a lot more reliably. There's a few tests that are pretty much dummy tests because it hurts as the positive response. Clark's sign with the knee is one of them, to where if you do it, well, ow, that hurts. Okay, well, it's pretty much going to hurt everybody. Does it hurt more than the other knee? I know what you're getting at. So there's a few ones that are kind of like that. All right. So that gets us to the majority of, well, the forearm. So that gets us to the wrist and hand. Draw a big fat line on your paper, because that's as far as I can get with the other class, and so this is the extent of which I will damage you for the next exam. So as we go through the hand and wrist, the wrist, hand, and fingers, that stuff will be going into that next test, into the final. So it will be off of our third exam. Okay, so we'll just get a little bit ahead of them, because we can. But knowing me, I'll leave some questions of the hand and fingers and wrist on there, because I won't pull all of them off, and then somebody will freak out on me, and then I'll have to make adjustments. It'll be all good. I'm not sure that you're my most vocal freak out person at this point in my life.
Really?
Really.
Wow, I'm sorry.
You should try harder. Really kind of just...
I'll strive for improvement.
All right. Things that we need to go over. Let's plug it up. We'll do it this way. Yay! Things we need to go over. In PowerPoint form.
Nice fire. On Blackboard.
Yes, it is. So you can pull it down now if you wanted to, and then put notes all over it. It's entirely up to you. but PowerPoints do exist. I used to teach from them. If I can avoid it, I try to. I find them tremendous. Alright, bones, extrinsic tendons. We've done all of those, but we will find them as they cross over the wrist. Synovial sheathing, we just referenced that. Retinaculum's to hold all those in place. Then we get into the intrinsics, the thenar, the hypothenar, the interosseous, and then ligaments of support. So yay for bones. If you have not memorized your bones of the hand and wrist, you are behind, and you should. It will help you tremendously in terms of life. So, easy way to remember them, at least to get the kind of the first letter down for each one. So we have scaphoid lunate. Let's see if I can mouse it up. Nope, I don't have that. Do I have that? I do. Okay. All right. So, over here. Good. Oh no. Sorry. So scaphoid. So thumb side. Orient yourself first. Thumb side. There's the scaphoid. There's the lunate. There's the triquetrum, and there's the pisiform. So that makes row 1. We have 8 bones. There's a bottom row and a top row. So the proximal row: scaphoid, lunate, triquetrum, pisiform. Pisiform has been referenced as a bit of a sesamoid bone at times. It's embedded within ligaments, but not within a tendon, so it's more of just kind of a floater. It sits on top of triquetrum, elevates the depth of the wrist, the depth of the palm of the hand. Then we have, going again from the thumb side, so more proximal, more distal towards the first metacarpal, we have trapezium, then trapezoid, then capitate, and then hamate. And hamate has a hook on it, so it has a bony protrusion towards the anterior surface. So where the pisiform is sitting on top of the triquetrum, the hamate has a projection that comes up to match the pisiform, so it's like an elevation. It creates a bony tunnel. There's a ligament that goes between them to kind of cap that off. So it's creating a space under which we can pass the deep branch of the ulnar nerve. So we'll come to it momentarily with a better image so you can kind of hold on to that. Okay? So to remember those, scaphoid, capitate, triquetrum, pisiform, trapezium, trapezoid, wait, scaphoid, lunate, I think I messed that up. Trapezium, trapezoid, capitate, then hamate. Some lovers try positions that they can't handle. First letter of each one. Easy enough? Excellent. Good talk. Next we have, like the long bones of the feet, in the main part of the palm of our hand are the metacarpals, which at the metacarpal phalangeal joint, the MCP, which is your knuckles, you then get to the phalanges. So all of them have a proximal, middle, distal, except for the thumb, which is proximal and distal. There's only 2 segments there. And there's a couple unique little extra pieces in here too. So if you notice, especially under the thumb, we have 2 little sesamoid bones. There's another one on the pinky. But you have some bones that help with leverage to where I can push on it. And so again, that's at this joint here, metacarpal phalangeal joint, there's a pair of sesamoids sitting right in there. So that you can have pressure on it with tendons being able to go underneath. Yay, bones. And more bones. So there's your hamate right there. It has that little hook that sticks up. So it's right there. Or pisiform's right there. So you have this little passageway called Guyon's Canal. All right, some more terms. I'll spell Guyon's in a moment. G-U-Y-O-N-S. Or less than a moment. If you look at your hand, it naturally has this like curvature to it. So the bones are arranged to where there's an arcing of those carpal bones in a U shape, over which we have a flexor retinaculum that kind of helps hold it up and cradle it in. Through there we have the majority of our tendons, as well as the median nerve. This is the location of carpal tunnel syndrome. So the carpal tunnel is that flexor retinaculum, that palmar that goes over the top, keeping that archway supported through which we have that tunnel. And if there's irritation, inflammation, there's not a lot of space in there. And so because of that, if you get swelling, it tends to squish everything else, and that nerve gets to be one of those squished things. One of the last resort surgeries they'll do is actually release the carpal tunnel to open up all of that space in hopes that it will help some. So, principal landmarks if you're looking at the fat meaty part of your hand. Under your thumb, so the big, massive, waddy, it's not mobile wad of 3 because that's back here, but you've got this nice big chunk of meat underneath your thumb. That's your thenar eminence, T-H-E-N-A-R, thenar eminence. So my hand is sitting like this, and then I go below my thenar eminence, under my pinky finger, which is the other kind of obvious, big, fatty, lots of muscle kind of place in your hand. You have your hypothenar eminence, hypo being below, so hypothenar eminence is below the thenar eminence. So what do you know? Thenar space, that's the thenar eminence right there, and then you have your hypothenar, well, fascia, but hypothenar eminence right there. There's a median, a mid-palmar space, there's a median compartment as well. And we'll get to those muscles. So, hypothenar, thenar, and then the central, palmar aponeurosis. And there's an adductor space, but it's just the adductor muscle, so it'll be easy to figure out. So we'll start with our thenars first. Hypothenar, little one, under the little finger, abductor, digiti minimi, flexor, digiti minimi, and then opponent's digiti minimi. So if you remember to the foot, I mean these are the intrinsics of the hand, if you go back and review your foot, it's going to look a lot alike. We had a flexor digiti minimi, we had an abductor digiti minimi. Depending upon the resource, some of them say we have an opponent's. But I don't seem to see that show up everywhere, so we left it off. You do have an opponent's in the hand. What does opponents do? Articulate it, use your words. Because you're not even opponent. Opponent is in your pinky finger. What does it do? You're right. But it's kind of, sort of. I mean, it's opposition, so it opposes. It brings my pinky into my thumb. It's cheating just to make your thumb. Both. So, abductor digiti minimi, flexor digiti minimi. Ooh, wow, I can spell. And opponent's digiti minimi. That's the other reason I don't use that PowerPoint, because you guys start seeing my bad spelling. Thenar intrinsics, thenar eminence, abductor pollicus brevis, flexor pollicus brevis, opponent's pollicus. It's like a mirror image. Not meant to be crazy hard. Just like in the foot. We had a flexor hallucis brevis. We had an abductor hallucis. And again with the opponent's thing. And there's an adductor compartment, which is really the web of your hand. So adductor pollicus is this space between, well, it's where we were trying to palpate that, right in here between your index finger and your thumb. So what you're feeling in there is actually your adductor pollicus muscle. There's two heads of it, separated by the radial artery as it forms deep palmar arch. Again, you can feel your pulse in that area. And then the central compartment. Lumbricals, pad and dab. Remember all those? Same exact theory, same exact process works for the hand. So lumbricals, are inserting into that dorsal hood, coming off of my extensor digitorum longus tendon. Is that you? Origin, comes off of FDP, flexor digitorum profundus. So it originates off of FDP and it inserts into the extensor expansion, the dorsal hood, into that blanket that covers the back of the finger to help pull it down. And then we have pad and dab. Dab is dorsal interossei AB ducts. Pad is palmar interossei AD ducts. Pad and dab. And just like before, my dorsal that can AB ducts, my dabs, there's 4 of them because your middle finger has 2 because it AB ducts either way it goes because it is the midline. My palmar, there's only 3 and my middle finger doesn't have any because you can't adduct yourself back towards yourself. Because it is the midline, you can't bring it back to the midline. You just have to shut off the dab and it will come back in. Forearm tendons. Lots going on. We talked about most of this, just going over the sheathing. So this is your flexor retinaculum. It crosses over those carpal bones, creating that carpal tunnel. And we have this pretty expansive synovial sheathing, the flexor synovial sheath, that holds FDS and FDP in it. And recognize that as that sheathing goes up through those fingers, it exists all the way up to the distal insertions of FDP. And you've got a lot of little tethers that hold it in place. So when we avulse that FDP, it retracts quite a ways. There's the potential to retract quite a ways. So we've got to go back in and fish it out. So osseous fibers tunnel anchors the sheathing to the bone, helps prevent bowstringing, provides a tunnel for the tendon to move. Flexor retinaculum anchors the tendons at the wrist, creates the carpal tunnel, also known as the transverse carpal ligament. So it goes from the base of the scaphoid across the lunate to the triquetral. Allows passage for the median nerve and deep flexors. Radial artery passes superficial, it does not go through it. Alrighty, so median nerve is right here. So it comes in, it shoots underneath that flexor retinaculum, and then goes and innervates the thumb side of the hand. The ulnar nerve, and we'll come back to nerves later once we get through brachial plexus, but that ulnar nerve is going to come, that's your funny bone, so it's coming on that side, behind your medial epicondyle. It runs along that median side, goes to flexor carpi ulnaris on the ulnar side, and FDP for the 4th and 5th digit, which are again on the ulnar side. So the ulnar nerve does things on the ulnar side of the arm, and then you'll see that we have, this is your pisiform, and there's your hook of the hamate. And there's a ligament that runs between it that covers it up and through it, so there's your ulnar nerve peeking up, and the deep branch actually goes through that space. So the term is, anybody here a bicyclist, like a road bikes? Not so much? Yeah? So if you ever ride your bikes a lot, all of a sudden, like if you don't wear gloves, your 4th and 5th digit tends to get really numb. Like you'll get done, hour ride, hour and a half ride, and you can't feel anything in your hand on that side. It's called cyclist palsy, so it's where the handlebars are repeatedly smashing right on this spacing right in here. underneath your pinky finger in the base of your hand as you kind of ride the bike. And that vibration kind of is a little bit of a palsy. It causes palsy in the nerve. It stops sending signals as well. So we're damaging that deep ulnar nerve as it hammers into Guyon's canal. You take skiing, or sometimes with baseball players, where you're holding a pole and you fall, where you hit a bat really hard on a ball and it just vibrates just the right way, you can actually crack off the hook of the hamate from that vibration. So it's a skier's injury. Frequently you fall with that pole in your hand, that pole just drives into that hook of the hamate and you can crack it.
Fun stuff.
So median nerve comes through, goes to that flexor retinaculum, and then ulnar nerve, the deep branch, goes inside Guyon's canal. That's how you spell Guyon. Exactly like it sounds. Guyon. Canal of Guyon. Cyclist palsy. I think I just said all that. Except the name of the piezohamate ligament. Palmar aponeurosis. Palmaris brevis, extension of palmaris longus tendon, forms 4 longitudinal digital bands. Don't worry about doing too much. This is a cool picture of FDS splitting and FDP sliding through. It's a little bit better than just a drawing. So again, FDS, superficial, goes and attaches first because it splits. So it can insert into the middle phalanx, and then FDP slides to that slot and goes to the distal. So this is how you can see FDP coming up, goes through that slot and attaches. So if we have Volstead attached there, it then tends to kind of retract back. Here's a lumbrical coming off of the FDP tendon going into the proximal phalanx. This makes up your extensor hood. So you can see how we have your dorsal interosseous tucking underneath it, but you have your lumbricals as well as the extensor digitorum that all kind of create this blanket of a meshwork around your metacarpal phalangeal joint over your first phalanx, your proximal phalanx, to then then extend out to the distal attachment. So just a lot of attachment places in there. Extensor retinaculum goes over the back of the hand. Likewise, we have synovial sheathing underneath it. There's better pictures of the dorsal hood and all the stuff that kind of feeds into it. All right, so dorsal hood, extensor digitorum comes up, and it's got fibers that go down to go around the proximal interphalangeal joint to then reconnect to go to the distal. It also has fibers that run up the middle and insert into the middle phalanx. This becomes important. Injury called a boutonniere's deformity. Boutonniere's is buttonhole deformity. So if I take that location and I have something, again, like much like mallet finger that ruptures the extensor digitorum here, if I hit it a little bit further down to where I avulse it at that proximal joint instead of the distal, it's popping this piece here, but it leaves the rest intact. So I'll still have the ability to flex my joints. If I ask them to flex my distal, to extend my joints. If I ask them to extend the distal, they can. If I ask them to extend the proximal, they'll have a few issues. Because that attachment that goes over the joint is a little bit of a problem. It's detached. Okay, so it snaps there, retracts. Doesn't really track very far, but it just detaches. Because that dorsal hood, again, holds everything in place. So if you think about a buttonhole on a shirt, it's kind of a gap that opens up, and then you push the button through. So if I detach that attachment, the proximal, and I as a therapist, as an athletic trainer, don't catch it, then within about 2 weeks, the joint can actually, like a buttonhole, slip its way in between the bands on either side. So it pops its way out, and it leaves me with a hyperextension of my DIP distal interphalangeal, and a flexion of my proximal. So this is what Boutonniere's deformity will present as. Now, if you can catch it within the first day or so of injury, within the first couple days of injury, and you can splint it in extension, it will heal itself, just like you can with mallet finger. Hyperextension there, it'll heal itself. Once that deformity shows up, it will require surgical resection or surgical fixation. So you catch it early, good job. If not, they have to have surgery. But it's one of those that's kind of funky to understand exactly what people are talking about when you see where those ruptures are associated with a finger injury. Finger ligaments. So we have collateral ligaments on either side. And we have a palmar ligament. So there's on the anterior side, this is called a volar plate, V-O-L-A-R. So the volar plate is a restriction on the palmar side that prevents me from going into hyperextension. Anybody here call them like double jointed? You can do that. Yeah? Yeah, show that. Okay, so look at ring finger is the best one, I think. So that ring finger to where it goes into hyperextension at the proximal, and then she goes into flexion at the distal. So that's a laxity within the volar plate. It's allowing it to go too far forward, and then the other muscle, she's locking it in that position and then being able to flex the distal tip. So that's another injury where you have somebody who has if they're not normally that special, and they get a hit to it or a hyperextension to the finger that stretches it out. It's called a swan neck deformity because it kind of looks like a swan's neck, whatever position you're doing. So volar plate flexing, stretched, hyperextended gives me a swan neck deformity. So this finger in extension and in flexion should be a firm end field because it's got ligamentous limitations. But banding, collateral ligaments on either side, you can definitely sprain them. If you ever work football, you definitely can see people dislocate them. Typically the right answer, if you're ever asked, is that we don't reduce injuries, we don't reduce fingers, we don't reduce dislocations is what I'm looking for. But football coaches have a very low patience and a very low tolerance for that because they will just come up behind you and do it themselves. Now, the concern I have is with this volar plate. So if you dislocate and then you just distract to pull it back in, there's a very real likelihood that a piece of that volar plate can get lodged inside that joint space, which will cause long-term damage to the hand. It will limit range of motion in that hand. So anytime you have an injury to the hand, it's one of those that this is such a vital piece of us interacting with the world. You need to have them followed up with an ortho or with a hand specialist, just to make sure, just to rule out that when that coach did pop that finger back in place, that volar plate didn't get slid inside that joint line to where they have limitations once they finish healing. Yes.
So I was telling Carla, I broke my finger in 8th grade, I think, and it dislocated like sideways.
Okay.
But I didn't realize it in the moment because I was in a volleyball game, and I didn't realize it. So I was grabbing my hand because it felt like kind of painful, but like adrenaline was going through me, and so I guess I put it back by myself, and
Hardcore.
it was like super swollen.
Yeah.
And so my mom was in the hospital at the time, so I didn't have anybody to take me to the doctor. So we sat with it for a good 2 weeks and realized that the swelling never went down. And so when I put it back into place, it shattered part of the bone, and I had to have surgery on it. And now, like you said, I can't bend my finger. It's literally stuck in this position because the surgery basically shot the ligaments and the muscles, so I can't bend it because I broke it here.
So, recommendation is if you have a hand
That's 'cause
injury,
they're breaking.
finger injuries for sure,
That's where they put it together.
get somebody to double check.
Yeah.
I mean, there are things that we can do as athletic trainers, as PTs and intervention that
That's where they had to put
I mean,
that
if it's
together.
avulsion of extensor digitorum, you can splint it. You're going to be okay. I'd still have them follow up with an ortho just to make sure. But hands, know them the best you can. Occupational therapy is a career that is 50% based on fixing hands. So there's a whole stinking lot of information to know about hand and hand rehabilitation. At which point I will fully acknowledge I am not a specialist. And so when I have injuries, I get opinions from those who are. So. Cool? Alright, so all the hand and wrist stuff, put that off till the final. We will stop in terms of this coming up to forearm musculature, extensors and flexors. Good?